Hi, so today I'm going to talk to you guys about one of my favorite subjects. Emergency critical care. This is probably going to be one of my favorite weeks outside of course, anesthesia and stuff, the comfortable things that I'm um, interested in talking about. Emergency critical care is one of the things that I originally started off with doing in my career. And so I really, really love talking about emergency critical care. And it's one of those things that gets updated, constantly as we learn things and go through stuff. So this is pretty much the basics of emergency critical care. And so if any of you guys look into doing emergency or working in the ICU, you'll definitely learn so much more. But as usual, this is the very basics of what you'll learn for the VTNE, and then it kind of stems from there. So um, I'll just kind of quickly go through this, as obviously this should be kind of just reminders from what you learned in school. Um, so the word triage is essentially meaning to sort. So when we are triaging anybody, we are triaging whether it is on the phone, it could be, or in the hospital. And we're also many times now triaging, whether it is on the computer too. So telemedicine is really big right now, especially with COVID going on, and even prior to COVID, telemedicine kind of started kicking off. So we have to ask a lot of really important questions fast, and get people to talk to you about what is truly going on. So it is really important to have active listening and to sort out that information that you're looking for from what owners are trying to deliver that information to you. So it's really, really important to be able to sort out that information. So we need to be able to triage these animals and get that information in less than about 5 minutes. So our survey that we're looking at is obviously like their airway, their breathing, their circulation, and then is there any active like disability that's going on with them, right? So are they having any type of, broken bone going on, or disability, meaning neurologic issue, or is there seizures going on? So thinking to that type of thing, mentation too is a big one as well. So just not acting to that, a true not acting right, that type of thing. So, um, and doing a CPR explanation that's quick and concise, that we really need to ask them. They may walk in the door completely fine, and BAR and happy, but they can go downhill really quick. The perfect one is that we had a Labrador that came in who swallowed a needle and was a septic abdomen. And in 10 minutes, crash and burn, had to be in surgery. And $17,000 later, was a brand new dog, but we needed to have a CPR code status on them. So, having those CPR explanations right away, so that we aren't waiting for, owners to truly have to have a long thought process. We are explaining this for 10 minutes, and letting them know that this is a priority. We need something right away. Their animal is very critical. Yes, if they aren't sure, they can pick CPR right away. And they can always change their mind later, but we need to have something written down, signed, and ready to go. So, and even in the hospitals that I worked for, we had open chest CPR, closed chest CPR, and do not resuscitate. That may not be at every practice that you work at, but I worked in specialty at the time, so we did have that opportunity. So it was something that we had to explain quickly and have available to them. Um, and the big way that I presented it was that we wanted to make sure that for the people who were very adamant about do not resuscitation, we just wanted to make sure that we had that available to them. And so we always asked every single owner that walked into the building about CPR, and and what they wanted to have on record. And so it usually went pretty well, but having a good explanation of how you went about doing that. Um, Oxygenation evaluation is really important to you. It doesn't necessarily mean, as you guys have learned, that you need to put an SpO2 on every single animal walking in the door. SpO2 doesn't necessarily indicate that an animal is oxygenating appropriately, right? You can put an animal that is bleeding out all over the place, and you can put an SpO2 monitor on them, and they still could be oxygenating from the SpO2 at 100%, right? But they're bleeding out everywhere, just gushing out blood everywhere. And you'll know that they are still oxygen dependent, right? They're bleeding out acutely and they're going to need oxygen. So SpO2 is not the best way to be able to evaluate oxygenation status. So there are so many other ways that we need to evaluate oxygenation. So same thing with head trauma animals. So evaluating oxygenation is so many other things, right? So we can use SpO2. It's a great indicator in some ways, and it's good in combination with things. I think that us using our brains many times can be great too. So, just kind of evaluating the patient, looking at their gum color, right? Looking at the fact that, hey, maybe some other disease processes can also mean that we might need oxygen. And oxygen, it hasn't really ever hurt anyone to them for the most part. And so it's a great drug. I always like to call oxygen a drug, right? Some people disagree with me, but it does get ordered for for people at times, right? So I will call it a drug, and it is also therapeutic. So um, it can be a great drug for a lot of animals, and it is helpful for a lot of animals. So um, if we're ever concerned, oxygen's not going to necessarily hurt an animal for the time being, if we're at least concerned and waiting for a doctor to evaluate the patient fully. So um, when we are triaging, four major organ systems that we want to look at right away. So again, before the doctor is evaluating our patient, right? We on triage are going to evaluate these organ systems before the doctor can look at them. So we're evaluating their cardiovascular system, their respiratory system, their neurologic system, and the renal system. Those are the four major systems that we need to evaluate before we can deem them okay enough or where they go in our triage list, right? So, how are they doing cardiovascularly? How are they doing respiratorily? How are they doing neurologically? And how's their renal function? Are they, is their renal function okay? And, do we have a black cat? Do we have something weird going on, where maybe it's a renal failure cat that's temp is really low, and she's just really down and out? Are this renal failure cat, is it a cat that's really pale at this time? And we're concerned for this cat, really. So we need to evaluate all of these organ systems first. There are four major ones right away in triage and in emergency wise, right? That doesn't mean that there are the four systems we only care about, but it means that those are four big ones we first will look at in our triage. Next, we want to look at our history, right? So we want to ask really important questions that kind of are investigating what could be going wrong in our major organ systems that we're looking at. And a lot of times when I was in triage, from what I kind of am doing with my organ system, I'm doing a lot of these things as I'm looking at the patient. And this does take a lot of time to get used to doing, multitasking in this sense. But again, remember, you're doing everything like this within that less than 5 second mode. So you're trying to make sure that you're keeping first your owner calm. You're trying to stay really calm during this. You're trying to reassure the owner, and you're getting that history that whole time. So it's really, really difficult to remain calm, keep them calm. Um, but at the same time, getting all the information, getting a great history and triage, and then putting them all in line where they need to go. So, um, having a good template of questions as well when you're doing that history is really important. And in your history, you want to ask really good open ended questions for owners rather than yes or no questions. In your template, it may say, is your animal eating or drinking? Or has your animal been eating and drinking? Which, on the sheet, that is a yes or no question. But you may want to form that question a little bit different, like how has um you know, Fluffy been eating and drinking, or what has Fluffy been eating and drinking lately? So that should be a little bit helpful in some of the ways that you form some of those questions. So the history is really guided by a CVT, okay, um, versus an owner. A lot of times owners like to put in some, you know, additional details in there. So you really have to guide the conversation and kind of move it in the right direction, and say, that's great that they've been eating and drinking. I'm glad that they've been doing that. Now let's talk about how have their bowel movements been going, or, have they been using the litter box a lot lately? Have you noticed any changes in the litter box? So really to kind of, I hate to say cut them off on any type of different details, but really guide that conversation. Like I said, use open ended questions, and then include yes, that primary complaint, and then the duration of the problem. Try to get kind of the true duration of the problem, and the date that maybe they really notice the problem if you can. And then also include any current drug therapies that they have been giving, and then also any kind of therapies that they may have started with their animal at home. A lot of people try to do any type of their own therapies as well. And then any kind of chronic medications and chronic illnesses their pet are dealing with as well. Um, Include any uh, heartworm medication, flea and tick medication, anything that they're currently on. Um, it's important too that if they're not on heartworm preventative and stuff as well, we do know that that could always be an issue as well. If they're coming in for, respiratory issues and they're not on heartworm prevention, that could always be something that we're dealing with, even in emergency cases. So respiratory. So these are, as you guys know, things that we want to listen for, look for. So again, any type of apnea, tachypnea, normal things that we typically see. Really, it's just trying to use our terminology correctly. Agonal breaths, remember that's just the last gasping breaths. I can't even tell you what, how many agonal breaths, unfortunately, I've seen in my career. Um, and, just trying to, just be there for owners, be there for each patient that you are there with. And it's a very difficult career, but we are doing the very best we can to make everything as painless and be with every patient during their greatest moments and the hardest moments too. So, but yeah, I mean, it's difficult. So, um, I I do like to show certain videos to kind of prepare you guys so that you know what certain things look like. Some of you guys obviously have seen whether or not certain agonal breaths look like, or shine strokes breaths look like. Because when you first see them in practice, you may not realize, like, oh my gosh, that's an agonal breath. So it's actually really hard to find certain things online. So you may hear in here just kind of what this one is, and I don't want you guys to freak out. But you'll see two cats in here. One of them is already deceased. The other one is, unfortunately, the kitten is dying. And it appears that this lady does not have an emergency vet open. So unfortunately, she doesn't have a lot of options other than to just be with her cat. So it's very difficult to deal with, but I do want to show you what this agonal breath looks like. So just take a peek.
She can't see. She's not doing any eye. She can't see. I think she's dying. Hey. Okay. Oh no, it's starting. Wait, no. Hey. Hey. You're not dead yet. Come on. You got your legs on. Okay, she got fur on. Oh, come on, really? What is that? No, you're not dead. No, not two cats in one night. Come on. I'm here. Oh no, you don't. Again. Shit.
So I kind of lied. The one that was behind her was actually still sleeping. I guess it was just another cat that passed away earlier. But as you can see in the beginning of the video, there was just that agonal breath that the cat was not aware that of anything, and even those movements afterwards, it's just the electrical impulses of the body that are still just firing off. So but it's really good for you guys to have an understanding of what all of that looks like, and even in cats sometimes, to even be aware and careful, because some of those agonal breaths, you putting your hand close by their mouths and stuff, you can get bit during those times. So just be cautious. So some other things just in the respiratory system. So keeping an eye on their effort during this time, and this is really important for cats, especially. I always worry about cats in emergency cases when they have labored, inspiratory and expiratory for sure. And then their posture is really important. Obviously a normal posture, but if they're willing to stand rather than sit, um, you know, for respiratory issues, if they won't sit down, if they're uncomfortable for their breathing, um, that really says a lot. So that definitely can mean, hey, they need to be on oxygen. Hey, we need to give them some sort of, medication that's going to help make them breathe. Another thing too is extending their neck or their mouth, lifting up their head of some sort. Whether or not it means, okay, there's something truly about their respiratory system in general, or if it means something else, whether they have fluid in their abdomen, whether it's even just nausea, it can mean so many different things, but it's some way or another. It could be cardiac issues, anything, some way or another. There's some sort of respiratory factor where they are uncomfortable in some sort of way, right? And we need to do something about it. They take priority. Respiratory issues, we really need to be cautious of because, cats, yes, but even dogs, that's a big, big issue. And if they're showing us that they're having an issue, that's saying something, right? As people, we'll show you right away that we're uncomfortable. We're big babies, but in animals, they don't show us um, they're being uncomfortable until it's a really big deal. So um, but we're the first front of all of this stuff. We need to be able to speak for them. We're their advocates, right? So we need to be able to try to catch these things as much as we possibly can, especially in emergency. And then we're the ones that talk for them. So I always say, like, I'm the Lorax for animals, right? And so I would, have to tell some of our doctors multiple times, be like, no, you need to look at this patient and point them in that direction, and that one can wait for now, and you need to come see this one right now. Um, because this one is just as important, and we can look at that one in a second, or that one's stable, this one's not stable right now. And whether we put a probe on its belly or probe on its chest and we tap its chest right now, or give it some medication, just for pain medication to make it feel better, or even if it needs a splint for some sort of reason or something like that, just to at least buy it some more time, just to stabilize all of them, then we do that. But we need to make sure that everyone's stable when they walk in the door. And so also noting, so we have noting their posture, their effort, and the depth of how they're breathing, right? Are they breathing deeply or are they shallow? So it's not just, a matter of, hey, what's their respiratory rate, but we need to note, okay, is that effort good? Is their posture good? Are they normal? Is the posture weird? And then the depth of how they're breathing. Is it like really deep? Is it shallow? How does that look? So, cardiovascular system. Okay, so the things that we see. So, this was kind of a fun thing that one of my students made me that I love. I still have it. I have it framed in my bedroom. And so it shows up on some of my Zoom calls sometimes. And so she made it out of gummy bears, and it's supposed to represent, for the most part, what mucous membranes would look like, or that kind of thing. So obviously, some of them don't quite match, but that's okay. It's so cute. But our mucous membranes are part of our cardiovascular system, right? So we have our pink, which is normal. That's kind of what we want. Our poor perfusion would be gray. Anemia is pale. Brick red would be septic shock. Also, brick red too would also be if you guys live in an area that gets really hot, or especially really hot in the summertime. So that would be like heat stroke. I've seen a huge number of heat stroke in my time, which is just god awful. Um, I will never forget the time I had a heat stroke, that were two chows that came in. And, you remember like two chows, right? They have the thickest coats in the world. And of course, they're heat stroke. They were outside all day, and they were in our lobby. They didn't even make it in, like pretty much in all the way through our door. And they were just splayed out on the tile when they came in, and they were both seizing on the tile when they walked in. So of course I'm running to the front with Valium to stop their seizure. And by the time they got back, their temps were too high to read, which is over 110 degrees. So we're bathing them and doing whatever we can to bring their temps down. And their clotting times were out of range. Um, so essentially, they're both going into DIC at this moment. So the owners, they couldn't afford to save both of them, or try to save both of them. So it became this, who has the better shot at this moment to live? And that was the one that they were going to try to save. And it was the worst feeling in the world, because they essentially put it almost on the veterinary staff to pick which dog they were going to euthanize out of the two, was the better shot, and it's like you don't want to ever be put in that position, of which one's going to be euthanized out of this disastrous mess after you've put you put so much work now into both of these dogs to try to save their lives. And now you have to euthanize one of them, you know? And it was so hard. It was such a hard thing to do. And that's a huge part of where we come into this moral distress and trauma and all of that in our field, I think. But, you know, as we did end up saving the one, and it thank goodness we did. And it is very hard, but we learned so much from all of those things, and I think that owner learned so much too, and he was so grateful that we did everything that we could do too. So I think that we have to look on the bright side of those types of things too, that we still were able to save one, even after it felt so horrible about the other ones as well. So, but yeah, you'll just remember those little ones that you're, of the heat stroke and those types of things, that get hard. But we actually save quite a bit of them for sure. And then blue is hypoxia. Yellow is hepatic dysfunction, which we see quite a bit. You'll also see, like in those hepatic, like fatty liver, right? So hepatic lipidosis, hemolysis, right? So especially those IMHA ones where we give them blood transfusions, and then all of a sudden they lyse all of all of the red blood cells that we gave them. They'll turn yellow after that. So again, it's like you go to fix them, right? And their immune system is just on overdrive, and so they lyse those red blood cells. They're like, nope, we don't want to work for you yet. So yeah, you keep battling, right? You keep battling with it. And then brown is methemoglobinemia. I hate saying that one. And that is acetaminophen toxicity. Okay. So our CRT, right? So normal is about 1 to 2 seconds. So prolonged is anything greater than 2 seconds. Rapid is less than 1 second. So when people write that it's less than 1 second, that doesn't mean that it's good, right? So we need to keep an eye on that as well. It means more hemoconcentrated. So our pulse as well. So you'll get this different in every single textbook, every single person you ask, like, what's the normal pulse for a dog and a cat and whatever. So you'll see something different anywhere that you look. And I think in some of my PowerPoints are all different too. So just keep that in mind. So dog is somewhere between 70 to 160. Tachycardic is anything over 180, remember. Okay, so again, it just depends on what size animal and that kind of thing. Cats, we're saying it's anywhere between 150 to 220. I think in one of my other slides, it said like anything about 100, which made me nervous because I was like, I think that's like bradycardic, but whatever. But that's what it said in one of the textbooks. So I was trying to stick with a textbook one, but it still made me weird. So somewhere within that realm, obviously, if it's on the VTNE, and just choose the best answer that's on there. And so pulse deficits you want to look for. So again, pulse deficits when you are listening to the heart rate with your stethoscope, and then what you're going to do is you're going to feel for the pulse. So you want to make sure that the pulse and the heart rate are matching up each time. So if you're feeling anything that's not matching up, that means that there's a pulse deficit. A lot of times, if there's a pulse deficit, that means that there's some sort of arrhythmia going on. So it's just indicating to you, like, hey, you need to actually do more of a workup on this patient, which is such a great idea and such a good advanced technical skill that you guys have. And then a pulse quality. So you want to say, okay, is this a normal, strong, weak, snappy, or bounding type of pulse? And so here it's telling you as well, like if it's a weak pulse, you might have some poor perfusion going on. If it's snappy, you could have some anemia going on, and bounding could be septic. All right, so nervous system. So, it's interesting. I used to be super, super afraid of uh, neurology. And then I worked alongside a couple neurologists, and I still don't know. I don't think half of what I think neurology is all about, but the more that I've learned about neurology, it's just so interesting. And so if you end up working in neurology, any of you guys, it is really incredibly interesting. So I really encourage you guys to be ambitious and someone work in neurology. There's not enough VTSs in neurology, by the way, either. I think there's literally a handful. So, but it is incredibly interesting. And these poor animals need so much help, and they need so much love and support from veterinary technicians. So I encourage as many people to really look into neurology. And um, there's a lot of great smart technicians in neurology. Not that there's not smart technicians in every other field or part of the field, but neurology is a really, really cool area. So when we look at the nervous system, we're looking at level of consciousness, right? So we want to see that if they're alert, if they're depressed, if they're quiet, do they have some sort of delirium or dementia? Do they respond to the environment that they're around? Stuporous, meaning that they're unresponsive to the environment that they're around, but they respond to pain, right? So some people will get stuporous and dementia confused. And comatose means that they're not responsive at all. So kind of keep that in mind. So stuporous means they're unresponsive to anything around them, but they only respond to pain. And dementia means that you respond to, the environmental stimuli, but you are just not quite right in the head. A gait. So what is their gait? Like, are they ataxic, and just or weak? Um, do they have a loss of motor function, a loss of deep pain? All right. So, like, we see this a lot with, of course, back dogs. So they could have ataxia or weakness if they've lost their motor function. That means that there is no motor function at all in like their back legs, or if it's a front leg. Even if it's a slight motor function, still means there's motor function. So you have to be really careful when you say there's a loss of motor function because it changes the percent of recovery. So you just have to be cautious. Now, loss of deep pain, same thing. Um, if even if it's a slight amount of deep pain, there's still deep pain there. So that's why they pinch so hard sometimes. And then muscular twitching. So it could be hypocalcemia. Usually, you get those indications like, oh, they just have puppies, stuff like that. So it's like, hypocalcemia, maybe hypoglycemia as well. Pyrethine toxicity happens quite frequently, especially, same thing like, oh, a cat just had, flea heartworm or flea product just put on, that kind of thing. So you kind of can think that. Other things that you might, and this is going to go under, uh, you know, toxicity though, is like a mold toxicity, but shows those signs of muscular twitching. So you kind of have to rule those guys out. Or again, like hypoglycemia as well. So kind of ruling out certain toxicities for the muscle twitching. So other things that they see in nervous system is head trauma, um, and then ruling out nystagmus. So we'll kind of get into that, and then head tilt, and then also head turn. So head tilt meaning literally that the head tilts on one side or the other, and head turn meaning that the head is turning to one side or the other. They can also have a head tilt and a turn, right? But you have to differentiate between one or the other. Okay. So let me make sure this video works. Oh no. I think this is going to show you. This is a video on. This is just a video on a little head trauma victim and it has really sad music, so I'll warn you, it's really sad music. But to not always count animals out, especially in emergency, that they might look pretty bad when they first come in, but we can get them fixed up pretty well, and they still have a pretty awesome life afterwards. So this guy came in, he looked pretty messed up. So, um, uh, yeah. So I apologize for the sad music, but I hope you take a peek at his story behind it because it's a really cool story of how they end up fixing him. So, oh, we skipped it. No.
comes a time when I won't belong. I'll be
So he ended up looking fairly good. I mean, with all of that work and everything, he's never going to look 100%, with, they're not plastic surgeons, of course, but he's eating and he's able to function appropriately, and he's with a nice, happy family. So the rest of that video was just them petting him the whole time and lipping on him. So, but, you can never truly factor them completely out right away when you see them. So that's a pretty amazing part is, if you can manage their pain and you can see a way of fixing them, it may take some time to heal, but that was a pretty amazing story that they're actually able to fix, the head trauma that he had. So here's another therapy that we've actually done. I've done even in when I worked specialty, which is really awesome. You pretty much can do it in so many different aspects of practice, especially in emergency, for like pancreatitis patients, for again wounds, head trauma for sure. In the case, with Milo, he would have been perfect for it. It helps with healing process so much faster. The only therapy you really can't use it for is cancer. Cancer loves oxygen, so we definitely don't want to use it in our oncology patients, but it's great for pretty much any type of patient. So I just want to show you guys this as well, so you'll enjoy it.
Rufus the Black Labrador is 13 years old. He suffers from a condition that gives him swelling and pain in his spine, and another that can make it difficult for him to stand and balance.
1, 2, 3.
But since having hyperbaric oxygen treatment, his energy has been restored.
He wasn't eating, he wasn't drinking, obviously couldn't stand, couldn't go to the toilet. So it's just fabulous to see the improvement.
His owner has found it so beneficial, Rufus has come back for more than 25 treatments.
What the machine does, it delivers up to 10 times of the normal oxygen level the animal would be able to intake under normal atmospheric pressure.
Hyperbaric oxygen therapy allows the oxygen to be infused into areas of compromised blood supply. It helps to reduce swelling, kill bacteria, and stimulate blood vessel growth.
Depending on the animal's condition, we will treat them between 30 minutes and 90 minutes.
The treatment has also worked wonders for Lincoln the cat, who suffered severe smoke inhalation after being trapped in a house fire. It can also help with spinal cord and cranial trauma, shock and wound treatment, and heat stroke. Dr. Mark Robson says enthusiasm for the treatment is building all over the world.
For animals with certain conditions, it's a very useful therapy to add on to what we normally do.
Pets usually relax and fall asleep during the treatment. There are only 3 animal hyperbaric chambers in the country, but every day they're breathing life into pets, just like Rufus. Alice Wilkins, News Hub.
Great. So life-threatening wounds. So these are things that we assess absolutely when they come in. And then obviously seeing the vet right away. So, bleeding, lacerations, punctures, we're gonna see right away. And then we assess them as CVTs and determine, okay, where are these coming from, these lacerations? Do they need to be seen at this very moment? And we wrap them up right away to contain any contamination, contusions as well. So if they're hit by cars, stuff like that, how's the animal doing currently, getting all these vitals and stuff, open fractures for sure. that needs to be seen right away and given pain medications, and again, wrapping those as well to contain any type of contaminations and stuff too. So this is why bandaging is so entirely important when you guys are learning. It doesn't have to be perfect, but just as much as you can contain what is going on at that given moment. So always making sure, getting okay for pain medications, keeping them in back so that you can keep them nice and still, and then, wrapping that area. Crepitus. So as you guys may know, if you feel any crepitus, so where it might feel like cellophane, um, like underneath the skin or anywhere on the body, that usually means that there's some sort of tear somewhere that's leaking air. So a lot of times you'll feel it somewhere in the chest, in the trachea, near the trachea, or there might be the chest, there might be a puncture wound somewhere that you're not seeing right away. So there's some sort of air leaking, and whether or not we can put a nice tight bandage around there so that no more air is going to leak in. So whether or not you can find that leak, um, we need to try to bandage that up and then potentially get some radiographs to see if we can find where that leak may be at the given moment. But that, of course, is going to entail obviously chatting with your vet to make sure we can get additional radiographs and talking to their owner as well. So they're going to be a little bit higher up on our triage list right away. Dislocations, of course, are going to be moved up on our triage list, so we can get them pain medications right away. Number one, that's not fun, of course. And then hopefully we can get them seen ASAP so we can get some rads in, some sedation, and get them seen. Dislocations take some time to be able to put them back in because some go back in pretty easily, but usually if they go back in pretty easily, they come back out pretty easily. So they usually end up being where we have to sedate them. We're going to keep them overnight and all of that jazz so that we can keep them calm and stuff overnight. So um, typically we're going to have them seen pretty quickly, but get them in and out of you know triaged, have the owner seen and stuff, admitted into the hospital. We can get them pain medications and get them started on stuff, so that we can at least get them anesthetized and um, try to relocate. Whatever's dislocated is fantastic. I would not want to sit with a dislocated, leg or whatever is dislocated for a long period of time. That's just no fun. So, and then treating any type of pain. I am way into pain management. I don't like being in pain. I guess it's maybe because I have a pain disorder myself. So it is not fun to live in pain. I will say I've lived with a pain disorder now for about 8 years, and it's horrible. And so I don't want to see anyone live in pain. So treating pain can, any way that we can treat it, that would be great. So um, if they're in pain, treat it right away, and just keep following up with treatment of it is just ideal. Like I said, wounds in the upper airway or abdominal cavity, at least bandaging it right away, tight bandage, and then trying to figure out where that is coming from. So if it's a flare chest, we need to make sure that we are treating that appropriately. Flare chest means that we have two broken ribs on the one side, that it could slice up our lungs if we don't treat it appropriately by laying them on those two broken ribs. Okay, so what you have to do, because they're literally free flying ribs in your chest, they're completely broken off, is that we need to literally lay them. So say those ribs are broken off on the left-hand side of your body, right? You have to lay them on their left side of their body, like their left lateral side of their body, so that the ribs don't just keep flying around on their chest. I know it sounds cruel, but we don't want to risk them slicing up their lung. And then we'll end up wrapping their chest pretty tightly too, giving them good pain meds as well. And then they'll end up having surgery to fasten those fractured ribs with surgery right away, honestly. So that they don't have any more of a risk of hurting any more tissue in their chest. So, of course, any wounds to major blood vessels, we obviously would treat right away as much as we possibly could as well. So there are a bunch of different ways of monitoring pain. A big one that we typically use is Colorado State University's and their pain score. It's just a really easy pain score to be able to use for the entire hospital to be able to look at. So you want to try to use something that doctors understand, your technicians understand, assistants understand, anyone that's looking at any patients in any cage is going to be able to look at this and compare it to something and be able to be like, hey, this looks like it's changed. So you want to be able to look at it. So there's a bunch of different ones. So Colorado State University, and then there's also Gladslow one that's also pretty popular. So I'm not going to actually show this one either right now because I kind of went through that pretty quickly. So there's that. So some additional monitoring things. You guys should already know we've kind of gone through other things too, but it's good reminder. So monitoring things like arterial blood gases, you'll end up doing, especially in critical care. Arterial blood gases, your neurologic exam, especially if you're going to be working in an area where you have a neurologist or you see neurologic animals coming in. Ins and outs of urine. So again, you want them to be at least a matching, so that 1 to 2 mils per kg per hour, right? Blood pressure is really important. So whether or not you're doing Doppler blood pressures, osmometric blood pressures, or CBPs are important too, and then other blood screens as well. So we have our neurologic exam, which I'm going to show you guys right now. This is a pretty, if you work with a neurologist, you'll see all of these neurologic exam things done. I personally like to teach all of you guys how to do a neurologic exam so you know what these all are, in case you ever need to do them as well. But it's not something that you personally, I guess, will have to do on every single patient of yours, but I think it's good for you to know how to do them too. So yeah, once you become a more advanced technician and stuff like that too, you may start doing some of these things more and more, especially if you're going into specialty and stuff too. So I do like to show this. So there you go.
Good girl. Ready? I'm sorry. I'm sorry. Come here. Good. Yes, this is for you. Okay. Check for muscle symmetry tone. Good girl. That's very good girl. And good girl. Good girl. And then can you gag for me? Yeah. Ugh. Good girl. Okay. I think that's all of them. And then check for nystagmus. And that's good. And I see it when she moves her head. Thank goodness. And then, oh, don't look at the light. Good. Good girl. Good. Ready? So patellar. Sorry, Anyala. Patellar. Stay. Tibial. And then gastric. And then flexor withdrawal. And then Aria, you're okay. Good girl. And then the flexor withdrawal. Good girl. Yeah, I got it! Okay. There. Okay, good. And now anal tone. Let me see your little tail. Yes. Yes, okay. And then spinal hyperthesia. Good girl. All the way up. Say nope, no owies. Alright, good girl. And then range of motion of the tail. Good girl. And range of motion of the head. Can you look all the way down for me? And to the side for me. Good girl. And to the, come here. Good girl.
Great. So that is a full neurologic exam if you guys ever are doing that. So great. So when we monitor urination, we really should be monitoring our urination for any animal specifically that is on fluids, especially. But truly, if you have any patient that is hospitalized, we should somewhat be monitoring them when they're when they're in the hospital, right? And just have a general idea, like, are they urinating or not, right? So they should have a treatment sheet, and we should be monitoring if when they're going outside, or if there's a cat, are they going to the bathroom, in the litter box, stuff like that. And so if they're on fluids and they're going outside, we should also be weighing them as well, whether you do it every 12 hours or if you are doing weights every 6 hours, but you should be weighing them at least every single day, no less than every 24 hours, of course, but ideally I would say at least twice a day if they're on a decent amount of fluids. And, if we're doing 1 to 2 mils per kg per hour of urine output, that's great. If they're doing higher, then, kind of adjusting. If they're really having a huge amount of urine output, then kind of adjusting as needed. Um, and then if you have them, they're going to the bathroom or if they're gaining a lot of extra weight, just keep in mind that, um, 500 mils of fluid weighs about a pound. So if they have gained, a pound of since they have come into your hospital, um, then they have retained about 500 mils of fluid. Now, sometimes when they're dehydrated, that could be a good thing, but if they continue to gain weight and they've already been rehydrated, then we need to back down fluids a bit. So just keep that in mind. We are also there to alert the doctors. And again, we're the patient advocates. So we're the ones to say, hey, this dog is like continuing to gain weight after he's already been rehydrated. Are you sure you want to keep him on this much, fluids? And then it's up to the doctor at that point. So we've already alerted the doctor then. If the doctor says, yeah, let's keep him there, then we've already alerted the doctor. You write a note on the treatment sheet saying, alerted the doctor that we have gained weight and doctor wants to continue fluids the way that we are. And that's where we then say we're good. But if we don't alert the doctor, then that's on us too. So blood screens. So this is like one of my favorites, as I'm a big nerd too. So I always say like I have all these favorites, but I don't know why. Maybe I'm just a nerd in every aspect, right? So when they're in the hospital, we're always rechecking blood work. We have our baseline, right, from earlier of blood work when they first come in. So, we're rechecking blood work constantly to see like what has changed, are we getting better? Are we getting worse? Like, where are we at? Because many times when they come in, we don't really know what's going on. We're making, hypothesis a lot of times. Even the smartest criticalists that we know aren't always able to solve the case, right? And we're doing the very best that they can to be able to solve each case. So this is such a great picture because it has so many fun things in here, and I don't even know if you guys can find all of them. Because as I look in it, I'm like, oh, there's so many good ones. Like there's magenta inclusions in here where I'm able to figure out what that is, and then there's another blood parasite in here that is Babesia, and the other one I'm finding it obviously is distemper. Um, and then there's obviously our nucleated red blood cell. Um, and we have, just like a ton of, well, obviously spherocytes and, Heinz body, and then polychromatophils and our thrombocytes that not that many in here, but they're there. Um, so this is just a fun blood smear this is probably not a real blood smear, but there's just a bunch of cells that they threw in here so that could be fun. So, because I would really hate for this to be a real animal because it's a lot of badness. Um, but when we go and have our patient, we do a lot of different blood screens and recheck things constantly. So we recheck PCBs and total protein all the time. This is such an easy informational tool that we can do in our ICU, rechecking to see if they're anemic again, or if they're hemoconcentrating, or if their total protein is showing that they're still dehydrated, or if we are actually getting better with our total protein, where they're, potentially like if our protein was low before, and we're getting better with our protein content as well, so it goes both ways. And our BUN creatinine, like, is our BUN creatinine getting better or worse? Glucose is such an easy tool. We use it for so many things for our puppies, our older animals who are diabetics or diabetic ketoacidosis animals. We check electrolytes constantly in the ER ICU. We check potassium, right? Why is potassium so important? Um, and as you guys may know, it is can have a lot of negative cardiac effects on our animals if it gets too high, right? Um, and then we have our sodium potassium ratio, which can be interesting for our Addisonian patients. So we have our anion gap. Lactate is huge for perfusion. And so lactate is incredibly important, and we check it a ton in ER ICU. For our GDVs, we check it. In our seizure patients, we check it. And so what happens is that lactate shows us how well our tissues are perfusing, right? And so with like GDVs, when the stomach flips, there is a lack of perfusion that's happening, correct? So um, it gives us an early indication before we get to surgery what we're truly getting into, right? If our lactate is like 20, we know that the perfusion is pretty bad in our stomach at this point, right? Or anywhere in our gut. Like we know that the perfusion that the gut has been like this for at least some time compared to maybe the lactate being 4 or 5, where we're like, okay, we have a good chance that we can get that perfusion back to where it was supposed to be before, under 2. Like we can do this. It's going to be a lot safer. It's going to be better. If we're at 20, we're going to expect that we're going to have some necrosis going on by the time we get in there. So it's a good indicator of like what we're about to get ourselves into. So it's not to say that we're not going to be successful, but it's a good indicator of, all right, what do we need to set ourselves up for? And then, it's a great monitor then afterwards. We're not going to be able to put a window in this animal when we get out of surgery to be like, okay, we're able to see what's going on in the guts afterwards, but we can check our lactate to double check that perfusion afterwards to be like, okay, it was at 20, now we're at 10, so we're getting better. Perfusion's improving. Are we still improving over time? Now it's at 5. Okay, we're still improving. So maybe it's working. Maybe we just have to keep hydrating this animal, doing what we're doing. But if it's at 20 beforehand and we only get to like 17, obviously perfusion's not getting better. We'll have necrosis happening, that it hasn't improved. Things are still dying in there. And now we're gonna have to be concerned with potential sloughing in there and more dying tissue eventually. And this animal could potentially become septic, that this might not end up very well. So if that makes sense. So acid-base analysis. So we've already kind of talked about acid-base analysis, so pH, oxygenation. So this would be like arterial. Obviously, if you do venous, your oxygenation is going to be off, which is fine. It's just a matter of if you need the oxygenation. So if your patient is, cyanotic and you need the oxygenation status of them, that would be best. Now, this is the most accurate. So if you need the most accurate, you would need to do an arterial gas compared to an SpO2 or anything. This is the 100% most accurate compared to anything else. If not, you could do a venous one if you're just looking for acid base. So now, when we look at different types of emergencies, we'll talk about endocrine first. So I'm just going to kindly dust slightly on some of these because you guys have already kind of talked about them. So we have Estonian emergencies, DKA emergencies, hyperglycemic emergencies. So we'll talk about a little bit about insulinomas, and then hypocalcemia emergencies. So we'll talk a little bit about those. So I'll start. Oh, I guess I thought I had more slides with that. Oops, let me go back. I guess I didn't have individual slides. That's so weird. Okay, so Estonian Crisis. Those guys come in as an Estonian crisis. They come in with an increased salt intake, or I'm sorry, increased salt content. And so these guys need to be essentially really given a lot of fluid therapy. That's pretty much a huge part of it. And so that's where we are looking a lot at their sodium potassium ratio a lot of times when they initially come in. And so that is the biggest part. So we're essentially really having to just balance out a lot of their electrolytes during that process. So that's the their biggest Addisonian crisis. And so balancing out their sodium and potassium is the biggest part on that. Diabetic ketoacidosis they're diabetics. They a lot of times aren't really regulated 100% on their insulin, or they've had a recent change in their insulin. So what ends up happening is they have a buildup of ketones, and they become acidotic. So we've talked a little bit about this, but they essentially are going to come in and they're breathing really heavy because their body is trying to compensate for them being acidotic. And so there are times where they are on death's door. And so it's a matter of us really fluid diuresing them at this point because we're really trying to flush their system out of all of this extra sugar, literally. And so we are really diuresing them. We're really trying to push out those ketones as well, because their kidneys aren't really able to function appropriately with the ketones. They're not able to break down all of that. And with their body just being so acidotic as well, we really need to flush out their system. So, and we're trying to regulate them as well on their insulin. So what we typically do in that amount of time is it's a lot of balance. And so we are going to be monitoring their glucose usually every hour. So this is a big reason why we place a jugular catheter, so we don't have to poke them every hour. So we place a jugular catheter, we give them their IV fluids, and we take their glucose every hour. And then once we get to the point where their glucose kind of plateaus at a certain level, we're going to start an insulin drip on them that's in fluids. And so when we start them on an insulin drip, we're still monitoring their glucose every hour. And so we'll change their insulin drip every hour with the glucose based on where it's at, so that we can kind of plateau them on what their glucose ends up being. So, this way it kind of balances them out so that, like, say their blood glucose is at 350, and we start them on 10 mils of insulin that they're on right away. So then they slowly go down, with their glucose. So finally we get them to a level that's like 200, so that's a manageable level. So once we get them to that manageable level and they start eating and feeling better, because of course they're not going to feel great when their glucose is that high, right? Then we're going to be able to kind of wean them off of the injectable insulin. We can get them finally back to, the regular insulin that their owners have been giving them, to a more manageable insulin injectable, and monitor them for like that day and everything, and then get them home to their owner. So it's a matter of just balancing them back to the way that they were during kind of that crisis phase, if that makes sense. So it's very difficult, and unfortunately it takes some time to get them out of that crisis. But it does work out pretty well. Hyperglycemia happens with a lot of insulinomas, so they could have a tumor on their pancreas. This happens in some dogs a lot of times that have tumors on their pancreas, and we have to give them glycogen, or I'm not sorry, not glycogen. Yeah, I'm trying to think, glycogen. To be able to, glycogen in order to, I'm like, what am I? First, we start them with dextrose to see if that's going to work. Many times that doesn't work, and we end up going to glycogen. But the true way of trying to get it to fix is to remove that tumor. But whether or not they end up going and getting like chemotherapy and stuff for their insulinoma, that is also another opportunity too, that they can do that after surgery as well. So you'll also see this sometimes, obviously in ferrets, you'll see insulinomas happen quite frequently as well. So that's another thing that we've also done. Hypocalcemia, again, you'll see that a lot in post-pregnancy animals. So we have treated that with calcium carbonate, calcium gluconate. And then we send them home with calcium carbonate, so Tums. And then we stop them with feedings from the puppies or kittens, just because they have no more calcium to be able to give for themselves. So we'll have puppies or kittens just replace with either like goat's milk, or if they do milk replacer or anything like that. Or if it's time for them to wean, they can wean as well. So at that point. Awesome. So some abdominal emergencies that we see obviously are GDVs, which we kind of talked about, GI foreign bodies. So pretty much anything can be a GI foreign body, right? Peritonitis, so anything that is inflammatory within the peritoneum. Parvovirus, liver failure, and hemorrhagic gastroenteritis, so HGE, as you may hear it. And then pancreatitis, of course, too. So pancreatitis you see a lot of. So the pancreas is a very gentle organ. So that is a huge reason why you see so much pancreatitis, because anything could really disrupt it. Even if you're doing surgery and you accidentally touch the pancreas, it could really make the pancreas upset, and you can end up having the animal get pancreatitis from it. So GDV, so this is just an animal who unfortunately has a very, very bloated belly, has a GDV, just to kind of give you a picture of what that looks like. So you see abdominal distension, non-productive wrenching, pill, muddy mucous membranes, prolonged CRT, tachycardia, weak pulses, especially in the back limbs, because there's no flow to the back of the body, right? So again, this is hypovolemic shock, right? So because there's nothing going to the back of the body. So fluid therapy is our first treatment, because we need to be able to get fluid to the back of the heart, to the back of the body. We need to decompress the the stomach here, especially on these big bloats. So whether we do trocherization or gastric intubation or lavage, we've even done it before where we've passed an NG tube in these guys and tried to do suction that way, which takes forever. So I don't recommend doing that, but you can. Just remember for trocherizing, that air rises. So we want to trocarize them, yes, to hear the pinging sound, right? But remember that gas rises. So you're not going to want to trocarize them low in the stomach. You're going to trocarize them higher up in the stomach. Get abdominal radiographs up first, right? And then do serial lactates. Surgical intervention, unfortunately, is the only way. And then they're gonna be tacking down the stomach to be able to create a way for the stomach to adhere to the side wall of the abdomen. And we're monitoring the blood pressure and the ECG, of course, as well afterwards, and throughout the procedure as well too, because the body in general is just going to be shocky as well. You know, through everything that's been going through, and yeah, this is what you're gonna see on abdominal rads. So it kind of looks like what everyone says, like a smart pat. Let's see if this shows. Oh, everyone's removing their stuff. So this is how you're going to do an oral gastric tubing, or oral gastric intubation. The only thing, so this is fine. The only thing I would do differently is have this animal intubated, especially when you do oral gastric intubation for GEVs. You are going to be using a lot of water through this process. And so no one wants to create some sort of aspiration pneumonia. They were doing this as I think a checkoff for school, so they didn't intubate for it. So, but I personally would always recommend intubating these animals for this. Other people use this process for other things too, such as, you know, using this to give charcoal to animals who are absolutely 100% refused to do charcoal. But this is mainly used for being able to pass a tube for GDV surgery. So
Nothing should come out. She has been sorry, I'm gonna hit you in the face with the tube. That went much better. Now your tongue's out the way. Sit down. Okay. Done.
great. So when you remove the tube, you're just going to kink off that tube line, and then you'll remove it because you don't want any type of gross gastric stuff flinging out at you afterwards. So that's just a nice personal message to get to you guys. So parvovirus. So we actually, knock on wood, don't see as much as we used to, especially when I first started in practice. So thank goodness. But when we do see it, so we have vomiting and diarrhea, obviously, when they come in. They're pale, muddy mucous membranes, prolonged CRT. I can just remember like the feeling of the gums being just also like crazy cold feeling, even though sometimes they would have a fever. It's just weird. A lot of times these animals were malnourished. They were tachycardic. They might be hypoglycemic, maybe leukopenic, and then hypokalemic because of the fact that they were having crazy vomiting and diarrhea, right? So a big thing of treating is, I always say, just supportive care, because that's unfortunately a lot of what we could do at the time. So fluid therapy, antibiotics just due to secondary infection, antivirals were a big thing, especially I want to say we really started hitting them hard with antivirals in like 2005 maybe. We started really going hard with antivirals. That seemed to what we thought were working at the time. Who knows? Antiemetics and antidiarrheals, of course. Plasma transfusions we were really working with at that time too. IgG transfusions as well, because they had the low globulins. So if we could do it, we would. The biggest thing is nutrition. These guys have no nutrition, as you can tell in this picture here. This dog is like really bony. So if we could feed them in some way or another, or give them some sort of nutrition somehow, some energy, that would be awesome. So some sort of amino acid we would do. So there's what's called a aminosin, which is a protein. So we would give those guys, start them on aminosin, whether it's IV. We would do that just to get them some sort of nutrition in those poor little guys. And so you can do typically, if you guys have heard of like TPN, so total parental nutrition, which we're going to be covering in nutrition soon, which I'm so excited for. But even if we start what's called PPN, so partial parental nutrition, you don't have to have a central line. You could just have, you know, a PIC line in for those guys too. If they're really bad prognosis ones, to get them on some sort of nutrition, that should do that. And then we started doing fecal transfusions. So you can also just start a brand new good flora in there in them as well. So that seemed to work really well as well. Awesome. So neurologic things. So acute traumatic brain injuries. So change of mentation, pupil size, them being unresponsive. So whether it was mydriatic pupils, at least chorea, so one big pupil, one little one. Different postures. So Sharrington posture is a huge one for, you know, our back dogs that we quite often see. So here's our head trauma posture that we see. So some of our things that we give, so hypertonic solution, so like mannitol that we quite frequently use. So remember, the crystals in the mannitol solution is what holds the drug mannitol. So it has to be, the crystals have to be melted in the drug itself. So keeping them in a warm environment to make sure that those crystals stay melted is important. And so if you have your solution and you see crystals in it, whatever you draw up is not going to have the actual concentration of your drug correct. So it's important to put that drug in some sort of water bath ahead of time to melt it before you use it. Or if you have some sort of incubator to keep it melted. That's important too. So make sure that you make sure that you have that drug melted completely, so that you're giving the 20% solution or the 25% solution, whichever one you guys purchase, melted appropriately. Hypertonic saline, so whether it's 7% or 23% saline, is going to help kind of bring that swelling down and bring it back into the vessels. Cushing's reflex, so remember what that is, that your blood pressure is elevated, but you are bradycardic. So again, we're going to use that mannitol or hypertonic saline, or both, to bring down that swelling that's going on in your head. Elevate their head as well, to kind of bring down the swelling. Oxygen is so great as well for these guys. We want to oxygenate their brains for a long time. Control any seizures they may have. They can come at any time, so it's really good to have someone around them. Pain control as well. Watch for any sedation. So we don't want to sedate them, but we want to monitor for pain. So find drugs that are going to relieve pain, but not so much sedation effect. So think about that. Like, what are some good pain control drugs, but don't have like as much sedation, right? So alpha 2s are out. So, but what are some good pain control drugs, but that don't sedate them? So think on that. Or what are the best ones? Okay. And adequate ventilation. So give them good ventilation. Come back. I'm not sure. Yeah, I'm not sure what all my videos are. Okay. So here are some more spinal injuries. So you guys have probably seen these. So this is our Schiff-Sherrington position. I just love that term, Schiff-Sherrington, for some reason. So they could have plus or minus motor, right? And plus or minus deep pain. Yes. We're checking for CPs as well. So can they flip over their feet, right? That's CPs. Reflexes, we're checking those reflexes. And then we're also locating where is the spinal injury, right? So is it from C1 to C5? Is it somewhere between C5 to C7? Is it somewhere between T3 to L3? Somewhere between L3 to L7, or L7 S1, right? And so it's not just us looking at this, but it is, the other doctors that are on your staff, but we'll be able to differentiate where the location on the spine that this animal injured itself based on, does this animal have motor and deep pain? Can we see if it has CPs? How are its reflexes? And where on the back is it most painful, right? And yeah, all of the reflexes all together, that, just our regular neurologic exam, correct? So that's the cool part, is that by working with your emergency doctors, you guys will be able to see these things come together. And it's important to be able to find these things, because your neurologist isn't going to be there 24 hours a day. And so when they're at home, they're going to ask all of these questions. And if this dog's going to have motor, even though it's sitting like this, doesn't mean that it's going to have surgery that night. It's probably going to wait. If it has motor, it's going to wait until the morning to have surgery, because it doesn't mean that it's an emergency surgery. Now, if it doesn't have motor and it has deep pain and it just acutely became like this, then that becomes an emergency surgery. So there is quite the difference. And so you have to know what's different. Now, you also have to know what's motor and what isn't motor. And so even if you see this dog slightly move its leg, that's still motor compared to not moving at all. So it's really, really important to be able to tell the difference between those things too, because your neurologist can't be there 24 hours a day. So that's why it's really fun to be able to do this stuff and to learn. I'm not going to go too much into hemilaminectomies and stuff and what they look like, but your neurologist to be able to do these hemilaminectomy surgeries on these little tiny creatures like a dachshund or just like that other little tiny dog, there's no space on these little dogs to be able to get in between each vertebrae and to be able to scrape away all of those little tiny discs that were bulging out. So essentially what happens is on these animals that their discs, the reason why their backs fail on them like that is that the cushion of in between their um, vertebrae, so the little disc, I call them donuts, the jelly of the donut explodes out into kind of that open column space of their back. And it causes severe pain. And so, what the doctor has to do is they have to go in and kind of um, drill themselves in and scrape away all of the jelly to relieve all of the pain and pressure that that animal is in. And there's not a lot of room to work in there because they're so tiny. And so it's not like a human being where they do the exact same procedure with humans as they do with dogs. And so because they have to drill their way in, afterwards they have to put what's called bone wax in there. And so the bone wax just forms kind of basically a brand new bone-like material. But it is kind of cool that they are able to do that and help these animals. It takes time and recovery, but they're able to do that. So with seizures, there's localized versus generalized, right? There's not tonic-clonic. I'm sorry. There's localized versus general. We don't call them grand mal seizures. They're called tonic-clonic. So grand mal, if you just think about it, it means good bad. So or big bad. So we don't want to really call them that. We call them actually tonic-clonic. So we actually call it in the medical terminology tonic-clonic. Okay. So there's a difference between localized versus generalized. So generalized means tonic-clonic. Okay, so that means that an overall everywhere seizure that would be tonic-clonic. Okay. So again, we don't call them grand mal. That's actually in human terms for some reason. They do that. Us is tonic-clonic. Localized seizures are something different. So localized seizures meaning in one part of the body, essentially. So we have focal facial. So you may have an animal who's having just a focal seizures in just one area of the body, or like in their face. There's also fly biting seizures. So my dog especially had this. And so it just looked like he was like literally going after flies, which people are like, well, my dog like bites after flies. I'm like, but is he literally going after flies? Like I can't get his attention to get him to stop doing it, and he does it out of the random, and it is usually when he gets really stressed out in the day. So and then there's cluster seizures. So cluster seizures is something that happens more than, you know, 3 times within a 6-week period of time, and that's with them being on medication. So that's something different, obviously. Or it could be more than 3 seizures within 24 hours. Okay. An idiopathic epilepsy means that that is something that we don't know why they are having seizures. Like they've had a complete workup done, and there is no diagnosed reason why this animal is having seizures. We cannot figure it out. And status seizure means that they are continuing to have seizures over and over and over again over a period of 24 hours with it not stopping. Okay. So we do have a pre-ictyl phase, an aura phase, an ictyl phase, and a post-ictyl phase. So does that sound very familiar to you? Probably, because it's a lot like what people have with migraines, right? So pre-ictyl phase happens up to, many people say up to 72 hours prior to that they can tell. Same thing even with migraines, where you can pick up certain things that you may note that happens before you can have a seizure. This was a huge reason why I got my dog initially for my really bad migraines that I was diagnosed with, is that he can pick up certain scents and things that I do that I don't necessarily realize. And so that's called your pre-ictyl phase. So there are certain things that your body completely changes within this pre-ictyl phase that unless you are very keen to, or this happens a lot, you might not realize. And so like for myself, I had a 28-day migraine. And so, and I have chronic migraines. So I'm kind of used to some of the stuff that happens. Aura as well can happen. So right before you have a seizure. And then ictal phase is literally during that seizure. So that's the ictal phase. And then post-ictal phase is after that seizure, which can last 5-10 minutes or can last even up to a day afterwards. So some things that can be due to seizures is that it's inherited. It could be due to liver disease, kidney failure, brain tumors, hypoglycemia, obviously due to a brain trauma incident, or even certain toxins that you have. So other causes as well. So this is just kind of a nice little chart that I'll put up really quick. So again, like causes outside of the brain, causes inside of the brain, and then just idiopathic epilepsy that you can see. And then what are some treatments? So our first treatment that we've been doing for quite a long time is phenobarbital. And so a lot of people are trying to get away from phenobarbital just because of long-term use can cause a lot of liver issues and stuff. So we also utilize potassium bromide, which again can have a lot of issues with liver. We have to give it with food as well. Another newer, I'll say, drug choice that we used is Keppra. We also use zonisamide a lot more. And so that one has come available a lot more. It typically is used more for localized seizures, or supposed to be used more for localized seizures, but people have been using it for generalized seizures with success too. There are some people that have been trying CBD for seizure treatments, but it has not been studied enough yet for a true dose of seizures. So they do recommend starting out at 1 milligram per 10 pounds as a safe dose, and then kind of tailoring it to each patient's needs. I did go to some conferences last year, and I know Colorado State University is doing a ton of research on CBD right now for seizures especially. So there's a lot more to come on this soon. So we'll see more. But another thing too is GDV 26 acupuncture and acupressure points. You guys may know from your respiratory stimulant pressure point or acupuncture point as well. But this is also supposed to be a seizure treatment as well too. Some people utilize this as just a seizure treatment and altogether and do it every day on their animal, just in case, you know. So that might be something to try if you had an animal. I don't know that I would stick my finger there while they're having a seizure, but it's just something to think about. And then nutrition too. So, you know, just kind of keeping that in the back of your mind, like what nutritional needs can we think about for any animal who has seizures. So, you know, I think it depends on each certain situation. So if they have liver issues, what are we going, and they're having seizures with it, what can we do nutrition wise, right? It doesn't necessarily mean, oh my gosh, they're having idiopathic epilepsy, and so now we have to look at a nutritional need for that per se. But good nutrition is great for every single pet in my book. So diazepam midazolam we use to treat like status patients and seizures. Propofol as well can be used to treat status at a given moment. Sometimes diazepam and midazolam doesn't work, so we can do that. I'm just gonna kind of skip through that. So we got through our neurology section now, and I'm gonna take a break here, and we're gonna get back to toxicology in a little bit because that one's gonna take a little bit longer for us. So I will talk to you guys soon.